Okay, good morning, everybody from Canada and far and wide. Though virtual conferences aren't my total cup of tea, it seems like a perfect way to have this conference because it's about advancing pediatric pain care and equity in low and middle income countries. And really, everybody can't fly into Sick Kids for a conference, so virtual really is the way to go. And it might be new for some, but it is the future. And, even in Canada, it's a vast country with many areas that are underserviced in healthcare. And what we're going to learn this morning from Dr. Cardosa and others can be applied to every country. So I'm very pleased to introduce Dr. Mary Cardosa, who is the president-elect of the International Association for the Study of Pain, is a Malaysian pain specialist who's done pioneering work in the field of pain management in Malaysia, setting up the first acute pain service, the first multidisciplinary pain clinic, and the first inpatient palliative care unit in the Malaysian Ministry of Health. And this happened in respectively 93, 2000, and 2002. And I find it very interesting. Her multidisciplinary pain clinic opened in 2000 because Sick Kids, there must have been something in the air or water. That's when we opened our multidisciplinary clinic too. She was responsible for many things, including implementing pain as the fifth vital sign, spearheading many things in Malaysian. I could go on, and her CV is quite impressive, and it's almost heartbreaking. It's so wonderful in how she's been helping all these kids in Malaysia, and it seems like she's done incredible work. And I'm going to be quiet now and let you listen to the person you really want to listen to is Dr. Cardosa. So welcome, and we're delighted and honored to have you speak here today at this Sick Kids Pain Conference.
Thank you very much, Stephen, and thank you for that kind introduction. I have to admit that my work is not focused on pediatrics. I'm a pain specialist dealing mainly with adults, of course, although, of course, I do see kids at the same time. Thank you so much, Jen and Liz and others for inviting me to be part of your Sick Kids Pain conference. I'm very happy to be here. I will be focusing on pain education as a means of improving pain care in low and middle income countries, so LMICs. And as I said, I'm not focusing specifically on pediatrics, but I think that if you improve the pain services for the whole country, the whole whatever community that you are in, naturally pain in children will also improve. Although I would agree that you do need some other targeted initiatives to improve specifically pain care in children. So my disclaimer is that I'm not going to be talking specifically about kids. So anybody who's not in well, I better don't say anymore. So these are my other disclosures. I have received some honorarium for different doing work with different companies, but I don't have any conflict of interest for this lecture. So after giving you a background about the situation in LMICs regarding pain care, I will be talking about mainly education, all the different initiatives of ISP and others. And then I will zoom in on our experience in Southeast Asia, what we have done and what has been the impact. But as everybody knows, education itself may not be enough. So what else do we need to do? That will be, I will have some thoughts on that before ending my talk. So hopefully I will speak for about 30 minutes, and then we'll have some time left over for discussion. So globally, we know that pain is a significant public health issue. And this year, IASP has designated in our global year theme as the theme of pain management, research, and education in low and middle income settings. So your theme of your Congress is in line with this theme. The burden of pain is disproportionately higher in LMICs, and the disability due to pain conditions is expected to rise in the next few decades. As you can see in the diagrams on the right-hand side of my slide, we have the footprint of non-communicable diseases, which is in blue, and the musculoskeletal diseases, you see back pain, other musculoskeletal diseases, things like diabetes, headaches, a similar both in high income as well as low and middle income countries. And yet in low and middle income countries, we have less resources and higher population. So there is a treatment gap between what could be done and what is being done. And we feel that we could be doing much more even with limited resources. So LMICs constitute more than 80% of the world's population, but the research that is done mainly, even in what kind of pain services, pain care should be delivered, is really done in high-income countries. So there is, again, this bigger gap, a reason for the gap to be even bigger. This diagram just shows you that the impact of musculoskeletal disorders, as you see here, in 1990, it ranked as third in this is in low income countries, low SDIs, and it has gone up to number 2 in 2023. So it is a growing problem. So what are the obstacles to good pain management in low and middle income countries? So lack of knowledge about pain and its management, I think it's not just in LMICs. Of course, it is all over the place, including in high income countries. But in some of our societies, we also have cultural beliefs and attitudes that may be obstacles to pain and pain management. And unfortunately, there is this bias towards biomedical or curative approaches and a very high attractiveness of um, pain interventions, because it's something that people can do on their own. It's something that you can learn and then you can offer to patients. And also, that's what the insurance companies and a lot of medical systems pay for. So it's biomedical rather than biopsychosocial. Governments don't prioritize pain services. They prioritize reducing the prevalence and mortality from communicable, maternal, neonatal, and nutritional diseases, despite the fact that the disability burden of musculoskeletal impairments is actually very high. And this has been shown in the global burden of disease studies, as I showed you earlier. And yet, governments are actually more focused on reducing numbers, especially of mortality, maternal mortality, neonatal mortality, and so on and so forth. There are also lack of institutional and government national policies on pain, especially in LMICs. There's limited access to pain medications in a lot of countries, including morphine. And overall, this all on a background of overall limited resources, both in terms of personnel and facilities and equipment and so on and so forth. So there are many obstacles to good pain management. So how do we improve pain management? One of the ways is by education, because lack of education was identified as one of the biggest barriers to good pain management. And in low and middle income countries, and this was written a long time ago by Sir Michael Bond, who was president of ISP at that time. And in another article by Wayne Morris, who was recently finished his term as president of the World Federation of Societies of Anesthesiologists, WFSA, and Claire wrote about pain management in LMIC, saying that the key areas for improvement that we should focus on are advocacy, improving treatment availability, and education. But they did say that education is arguably the most important of these three, because with education, then you have advocacy, you build up what we call pain champions, who will then focus on setting up services and moving the agenda forward to improve pain management in their various communities and countries. So what are the education initiatives that we have done? And I will focus initially on IASP initiatives. We have conferences, of course, grants and fellowships, training programs, and we have this thing called PERF, Pain Education Resource Center. I'm not going to talk about all of it, obviously. And the ones that I highlighted in bold are the programs that reach out more to low and middle income countries. And I've just highlighted that in 2026, the World Congress on Pain will be held in Bangkok, which is in my part of the woods, far away for you in Canada, but hopefully there are many people from low and middle income countries who will be able to attend this Congress. So grants and fellowships, I won't talk very much about it because it is usually awarded to individuals, although it does have its own impact as well. What I will be focusing on is pain camps, a multidisciplinary pain center toolkit, and also another educational program called EPM, Essential Pain Management. So these are programs that we carried out in Southeast Asia. So these are the ones highlighted in bold on the right-hand side of this slide: the EPM, Essential Pain Management, the pain camp, Southeast Asia pain camps, and the multidisciplinary pain toolkit. And the bracket is the year in which these programs started. Apart from having a pain fellowship at the Siraj Hospital in Bangkok, which is a joint fellowship between funded by IASP and WFSA, the World Federation of Societies of Anesthesiologists. We also have another online educational program run by the University of Santo Tomas in the Philippines. But as I said, these are targeted at individuals, and I'm not going to talk more about it. The other programs are targeted at groups of healthcare professionals. So EPM, I will start with EPM. This is called Essential Pain Management. It's a one-day interactive workshop for doctors, nurses, and other healthcare professionals. And it's targets a multidisciplinary group. So we don't do workshops just for doctors or just for nurses, but we want a mixed group. It teaches a system for managing pain, and it uses the acronym RAT, as you can see in the top right-hand corner, which is recognize, assess, and treat, akin to the ABC of resuscitation. So you need to recognize pain, assess pain, and treat pain using both non-pharmacological as well as pharmacological approaches. It's a system for teaching others about managing pain. It was started in 2010 in Papua New Guinea, and is now taught in more than 60 countries throughout the world, including many Southeast Asian countries. So since the pandemic, there's an online module available free of charge from that link that you see on my slide. And it allows you to get a certificate of completion if you complete the module, which takes about 2 to 3 hours and can be done, doesn't have to be done at a single sitting. So EPM is something that we think is very important. It's like Pain 101. We think everybody should know about it, not just people working in a pain clinic, but all healthcare professionals who work with any kind of patients, because, pain is such a ubiquitous symptom. So apart from EPM, we also have in Southeast Asia pain management camps, which we have been running since 2011. In Bangkok was where we first started, and now we have just completed the 7th camp in Singapore in May this year. We run it in conjunction with the Congress of the Association of Southeast Asian Pain Societies, ASIAPS. And we used to run it for 5 days. It's a residential course. Now we run it for 4 days because we make them do EPM online before coming for the pain camp. It covers essential elements in pain topics, which are important in day-to-day clinical practice. And importantly, we talk about biopsychosocial framework as well as working in interdisciplinary teams. So everything is done teamwork. We have group discussions, we have case discussions, and we make them practice some of the skills that we want them to be able to implement when they go back to their own countries, their own communities. So that's the pain camps. Then in 2017, we started this project called the IASP Multidisciplinary Pain Center Toolkit, with the vision to improve the lives of people living with pain in Southeast Asia by increasing the capacity in the management of interdisciplinary pain in Southeast Asia. The focus was Southeast Asia because of the funding that we got. And we had a goal to provide local clinical leaders in pain management with the knowledge, skills, and training to be able to establish multidisciplinary pain centers based on interdisciplinary models of care. So that was our goal. We had a long time working on it. We had an international group together from different parts of the world, not just from Southeast Asia, but also Australia, UK, Denmark, and the US. And we had representatives from Myanmar, Indonesia, and Vietnam, which were our initial target countries, where we carried out our initial training. We had many meetings, face-to-face and virtual, and product of this was a manual, which you see on the right bottom corner, the Multidisciplinary Pain Center manual. And we also came up with a training module, which we were supposed to run face-to-face training, but in the end, we had to run virtual trainings in a couple of the countries. So we started off, before we wrote the manual, we started off by having presentations from representatives from Myanmar, Indonesia, and Vietnam to look at the challenges that they face. And it was the same as what I've outlined earlier: limited resources, heavy clinical workload, shortage of everybody, especially clinical psychologists. So they said no psychologists, therefore we just give injections. So pain not a priority, focus on curative and short-term treatments and biomedical approach. And again, the same problem of pain interventions, which were very attractive, easy to do, gives you immediate gratification, both for the patient as well as patient also looking for quick fix, right? And also the doctor feels good because the patient will say, my pain, I haven't had this amount of pain relief for, so many years. So it's something that people, it's a big challenge facing us in this part of in low and middle income countries, I think in other parts of the world as well. So we came up with this manual, which had 5 chapters. First, talking about how you make a case for setting up a multidisciplinary pain center, then who should be involved, what are the services and facilities, evaluations and measurements. And we had 1 chapter on case studies from Malaysia, my own clinic, Philippines, Dr. Joy K from the University of Santo Tomas, and Dr. Pongparadi Chow Dak Shetrin from Thailand, who set up the Siraj Multidisciplinary Pain Center. So the first case talked about why we need it, what is pain, burden of disease, and talk about what you're going to say to your minister if you meet him in the lift for 5 minutes. So your 5-minute pitch. And we do include this in the training as well. Then we talk about personnel who should be involved and what training they should receive. What are the different facilities and services your center should provide, and the different levels so we talk about, what is a unimodal, what is a multidisciplinary, what is interdisciplinary work. We differentiate between the two. And then we talk about how to evaluate and measure the work that you do. And as I said, we have case studies. We also have appendices giving some practical examples of things like your clinic layout, list of medicines that you need, and so on and so forth. So I will focus now on training, since this is about, this talk is about training and education. So we recommended training for different people involved in the multidisciplinary pain center. So entry-level training should be done by all personnel and other healthcare professionals in your clinical setting. And this was just EPM because it was already there. We thought we don't have to reinvent the wheel. We just use EPM either face-to-face or online, which gives everybody a basic understanding of the biopsychosocial framework of pain and what are all the different treatment options. Then we had intermediate level training, which is what I will elaborate on after this. And we also recommended that for the leadership of the Multidisciplinary Pain Center, you should have some advanced level training, which included an observation at a established multidisciplinary pain center and further specialist training in whatever area you are in. So our intermediate level training curriculum included clinical assessment of pain, management of different types of pain, acute, cancer and non-cancer pain, case formulation, pharmacological and non-pharmacological management of pain, including physical therapies and pain self-management approaches. And then we also had a segment on how to set up an MPC, basically talking about, basically talking about all the different components that I mentioned earlier. So we carried out training in 3 countries. In Myanmar, we managed to do a face-to-face training in 2019 before the pandemic broke out. And then because of the pandemic, we had to convert our Indonesian and Vietnam training to a virtual session carried out in 2021. But in fact, we had more participants in the Indonesian and Vietnam training, and we were able to have breakout rooms and group discussions as well through Zoom. And in fact, we even had simultaneous translation in the Vietnamese training because this was available through Zoom. So this is just an example of the slides that we use for Vietnam. The local Vietnamese in our team translated all the slides that we had come up with, and we had to give the talk in English. It was in English, but it was translated to Vietnam, but we had to look at the slides in Vietnamese. So we had the different content as well as quizzes and different diagrams all in Vietnamese. So what was the impact of these different pain education training programs? So we have been carrying out a lot of programs since about 15 years ago. So starting with the pain camps, we did a survey of those who had completed a pain camp, participated in a pain camp. This was from the first 2 groups. And obviously there was increased knowledge about pain, but importantly, increased involvement in clinical pain management, and some had even set up new pain services and were involved in setting up new pain chapters and took up leadership positions if there were existing pain chapters. They were more involved in pain education, and a number of participants, campers from the first 2 or 3 pain camps have now become faculty members in subsequent pain camps. So you can see on the right side of the slide that the level of involvement increased both in terms of clinical pain services as well as pain management training. And there was very positive feedback. In terms of the toolkit, we had, of course, knowledge. We assess knowledge. So they were supposed to understand multidisciplinary, interdisciplinary pain management, biopsychosocial, how to set up a pain clinic, the differences between acute and chronic pain, and so on and so forth. And the post-course evaluation showed that they were mostly quite confident in these knowledge areas. So increased knowledge and understanding, especially of multidisciplinary, interdisciplinary, and clinical application of biopsychosocial model. We also looked at skills in the toolkit training. So this was a little bit different from pain camp because we didn't, we focused on basic stuff, and we did a bit of skills training, but not that much. Whereas in the toolkit training, we actually did a lot of skills. We gave them a list of competencies that we thought that they should be able to do. So they should be able to assess and do a case formulation for each patient, especially those with chronic pain. They're supposed to be able to help patients to identify setting goals, to explain chronic pain to a patient, introduce activity pacing, talk about problem solving, and talk about relaxation. So this was in Myanmar. We asked them to do self-assessment prior to, so the first column is self-rating, pre, And we had levels of trainee, advanced trainee, competent, very competent, and expert, and most of them were either trainee level. After the training, which was 4 days or 8 days, depending on whether it was virtual or face to face. This was the Myanmar one. After the training, which was 4 days long, they actually rated themselves as competent, and some rated themselves very competent. And this was verified by observation by the trainers, slightly lower, but not more or less the same, at least achieve a competent level. This was and this competency was actually maintained after the training. So in Vietnam, we did a 6 months post training assessment. This was a self-assessment, and in a lot of skills, you can see the green bar, which is a competent level. So in terms of, knowledge increase, skills also, skills competency increase. And in line with this, new multidisciplinary pain clinics were set up, new services were set up, interdisciplinary teams were strengthened, team meetings were held more regularly prior to prior to the training. There was like ad hoc discussions on patients, but not regular team meetings. And all the participants said that, they were able to understand how to apply the biopsychosocial perspectives in their own clinical practice. Interestingly, the virtual training, even though, we didn't have the opportunity to interact that much with participants, we gave them homework to do between sessions. And so they actually had chance to go back either to their clinical practice or to practice with their colleagues on some of the skills that we taught them. For example, how to do a case formulation, or how to explain about pacing to a patient. And so they were able to practice, and they were able to come back and tell us their experience in this practice. There was more emphasis in participants' clinical practice on non-pharmacological approaches, including patient education and teaching the patient pain self-management skills. This is more from Vietnam and Indonesia because, unfortunately, because of the political situation in Myanmar, we don't have a lot of feedback from them. So in terms of pain education, there was more interest in pain self-management skills and a demand for training on this. There was presentations at local and international conferences by participants of the toolkit training. There were inclusion of topics like interdisciplinary pain management and pain self-management in conferences which were held, which were organized by anesthetists and neurologists and and also in pain conferences, of course, and not just about interventions and injections. EPM, or basic pain education, was conducted regularly for hospital and other institutional staff. And there was a lot of online teaching and clinical case discussions, both within the country as well as with us from external. As you see, this picture here is Dr. Zubaida, a clinical psychologist in Malaysia, conducting a training for those in Indonesia. And we also presented our work at World Congress in Toronto and also in Amsterdam. And within the country, they formed social media groups, so WhatsApp groups and whatever forms of communication they have. And they had their own social support system for people who were setting up this kind of services, which were different from what existed in the country at that point in time, which was more the interventional type of pain services. So in summary, there was impact on individuals. So healthcare professionals had improved skills and knowledge, increased interest, and increased commitment to pain services. In the country, there were new pain services set up, increased pain education activities, and new chapters. The Myanmar Society for the Study of Pain was set up, and more recently, the Vietnam Association for the Study of Pain. The pictures that you see here are from 2004. The VASP was inaugurated, And in 2000, and Lester Jones and I went there to join them for their conference. And we had done training with the Vietnamese before that. And in 2005, the pictures below, you see that this is the team that set up a multidisciplinary pain clinic at the Hanoi Medical Hospital, University Hospital. So they worked very fast, and there was a big impact of the training that we carried out in these countries. Of course, I think that the ongoing support and mentorship after the training was also very important, because we maintain contact nowadays with email, WhatsApp. It's easier to maintain contact. And regionally, there was increased cooperation, sharing of resources. And I think a lot of these people have become members of IASP and involved in IASP education and advocacy efforts. And I'm glad that IASP is moving more towards doing more in global advocacy towards getting more better pain services in the world. So what else do we need? I want to go back to our own experience again in Southeast Asia. And this article was written by Dr. Pong Paradi, who was one of the pioneers of pain in our region. The challenges we faced were the same. We were limited in resources. People didn't understand biopsychosocial. People wanted to just do interventions. There were no clinical psychologists. And we had our own basic, core duties to do. So we did it in addition to what we had. But we had also some strengths and some advantages, I would say. We were committed, we were enthusiastic, we were pain champions, as I mentioned. You just talk about pain all the time and people associate you with pain. We had a lot of ongoing support and training from clinicians that we had trained with in established multidisciplinary pain centers in high-income countries. And this mentorship, I think, is a very important part. And this is what we are trying to continue to give to the younger people in countries where these kind of services are not so well established. We had support from each other. So we knew what each other were doing. We helped each other. We supported each other, shared resources, and so on and so forth. And we also had support from IASP in the form of educational grants, visiting professorship, and training opportunities. And the Siraj Pain Fellowship was set up. Pain camps were started, and we had the toolkit project. Importantly, we had the formation of the ASAPS, the Association of Southeast Asian Pain Societies, which was bringing together 5 countries, initially, now 6 countries in Southeast Asia. So Malaysia, Singapore, Indonesia, Philippines, and Thailand. And then Myanmar came in a little bit later. And we had regular conferences, regular meetings, and we really helped each other. So this was what we did in Southeast Asia, and this was the examples that we had in our toolkit. But more than that, I also want to bring in an article that was written by Professor Cynthia Goh, who's a palliative care physician who's unfortunately not with us anymore. She did a lot of training on pain and palliative care in the Asia Pacific region. And she said that, pain training on its own is not enough. We need advocacy. We need recognition that this is important. We need drugs to be available. We need a national policy. So these are all the things that she said we needed. And I just wanted to give an example of what we did in Malaysia. When I was working in the Ministry of Health, we had, we tried to make them have a policy for better pain care. And so we had this thing called the Malaysian Pain-Free Program. We started off with pain as a fifth vital sign in 2008 and transformed this to the Pain-Free Hospital Program in 2011. And then it became the Pain-Free Program with other people coming on board, non-physicians, emergency physicians, dentists, and primary care doctors, all wanting to come on board in this pain-free program. And this resulted in changes in attitude, knowledge, and practice. The recruiting of more what we call pain champions, not just from anesthesia and pain medicine, but also from other disciplines, including pediatrics, of course. a more publicity and public awareness about pain management. So I think that even though we are still not there in Malaysia, we still have a very long way to go. We also have administrative support when we have programs like this in improving pain care in our hospitals and clinics. So I just want to end with this. I wrote this article promoting multidisciplinary pain care. Although we have many challenges, we can do something with our limited resources. We should have skills training. The training that we carry out, education is not just on knowledge, it has to incorporate skills as well. And mentorship, I think, is very important. Ongoing relationship and communication with those that you have trained. Time and commitment is very important, but I think it's worthwhile. And advocacy is needed as well. So we need to ramp up our efforts, I think, in advocacy. And this is, I think, the role of IASP in partnership with our chapters and federations in working together for pain relief throughout the world. So I just want to end by thanking all the people acknowledging all the people that we have worked with throughout the years in different countries, different parts of, especially in Southeast Asia, and invite you again to attend the World Congress in Pain in Bangkok in October next year. So thank you very much for your attention.
Mary, thank you for a brilliant talk. I don't know how you've had time to sleep in the last few decades with the incredible work you've done. And Malaysia's.
That's why I showed you the team. The team is a team effort.
I agree. It's totally a team, and that team is often a team of champions. Here at Sick Kids, we have champions like Jennifer Stinson, Fiona Campbell, and many others. And without that entire team, it can't be done. So if you were tuning in today to this virtual conference and had some advice on somebody that doesn't have a multidisciplinary pain center or clinic, what would your advice be to advise them on where to begin?
Where to begin? That is a good point. First, I think you have to find your friends. So you have to find other people who are interested in doing the same kind of work, who are concerned about the problems that you want to address. I think first you have to find your friends. So you have to have coffee with lots of people. You have to talk to lots of people about what you're doing, what kind of work can be done. In the course of your day-to-day work, I think you look out for people who share the same concerns as you about, somebody who shows distress when a child cries, when they have a painful procedure done, and people just, hold, I don't know, in Malaysia, they just wrap the child up. They call it bundling the child, and do cruel things like that, and then send the parents out of the room, and things like that. If you see things like that happening and you see who is distressed with this, you go and get them to be your friend and say, hey, we better do something about this. So I think find your friends first, and then after that, I think reach out to people who have, who have set up such services, to say, I need to train a team here. What shall I do? And I think EPM is a starting point for everyone. Now we have a PEDS version. So Angela Yeo and her colleagues in Singapore have come up with a pediatric EPM PEDS. Okay, so they focus more on pediatrics. And I think that should be available. Maybe Fiona or Liz or Jen can, I can give you the contact of Angela Yeo, and you can get the EPM PEDS, and do that with your team. Get them to do, it's a face-to-face, it's not the online version. So you can run a workshop. We ran one at the ASIAP's Congress in Singapore in May this year. And next year in Malaysia, we are going to run one for our Malaysian Malaysian population as healthcare professionals as well. So it's already there, EPM PEDS. Or if you want to have an online version, then you can do the EPM online. I can also send the link. You go to It's run by a service by a group called Prax Hub, Praxhub, in Australia, and you have to register with Prax Hub, and then they have lots of education programs, but you look for EPM online and you'll find it, and you can just do it, and there's no charge at all. So get everybody to do that, to have a basic understanding. And it's always it's something that people find interesting, doable, and I think it does inspire them to look at pain as more than just a biological or pathological phenomenon.
I have a question here from Jen Stinson. She compliments you on your great talk, and she wondered, can you let us know what IASP is doing to update the interprofessional educational curriculum?
Thanks, Jen. Nice to see you. And thank you for the invitation. Well, we are going to review we are reviewing the the educational programs working group is just getting a group together to review this interprofessional curriculum, and we are trying to see first how it aligns. First, we were thinking of actually coming up with educational materials which people can use, can do, can modules that our members or not even if you're not a member could do. But then we thought that that is a lot of work. So what we are starting off with is looking at the refresher courses that we are going to run in conjunction with World Congress, and how and see where they fit into the curriculum, and sort of use that as a starting point um, to develop some actual modules, training modules, educational modules for the interprofessional curriculum. But we are reviewing it, and I think that Judy Watson and her colleagues have actually updated it recently. So we are going to look at it more carefully. Thanks, Jen.
Fiona, did you have any questions for Mary?
I did just want to comment that, Mary, it's really incredible what you've done. And I agree that education is massively important, along with sort of awareness, but we really got to take action, right? So
Yeah.
I believe it is in the chat as well, but there is a online pediatric pain curriculum that does align with the older versions, but it has more modern material as well. But there is an online pediatric pain curriculum through the Pain Center, but with lots of international experts contributing. So for people who are interested in the pediatric freely available online mobile friendly curriculum, there is that's available now. And I hope lots of people go to the World Congress. That's great that it's in Thailand. That's amazing. Thanks again for amazing talk.
Hey, thanks for inviting me. Oh, it's great. Angela is speaking tomorrow, so you can ask her about EPM PEDS as well. Because I think for us who are working in the field, it's good to have a curriculum that is more detailed. But we also want people who are not pain specialists or not so interested in pain, to get at least have some basic understanding, and I think EPM PEDS will give them that. So I think it's also a useful resource, and you can ask Angela about that tomorrow.
So, Mary, you're an inspiration to the world. IASP is so lucky to have you as their president-elect, and you've inspired me to want to go to Thailand
Bangkok, yes.
next October, so I can give you a hug in person.
Yes, I want to see you, Stephen.
Absolutely. It's now on my bucket list. I might drop in Japan first because I want to go there too, but Thailand is Bangkok is the
The draw.
the draw. Now,
Yeah.
now if anybody listening has any other questions or they can email the pain.center, CENTRE, at sickkids.ca with their questions, or the Pain Center at Sick Kids on the internet virtual has a vast amount of information that people can explore. It's updated regularly, and it's really a wonderful source, as is IASP. And I thank you for alerting us to all those resources that IASP also has available for those who are not only experienced, but the less experienced, to gain knowledge in education, which is really, I agree, a key to really optimizing pain in adults, children, and pretty well everyone. Again, I want to thank you, and thank you. I don't know what time it is wherever you are, but it's early in the morning here. But thank you for being so bright, energetic, and informative. I loved listening to you, and I think you're an inspiration for everybody.
Thanks, Stephen. Thank you very much. It's 10:45 at night here, but I'm a night bird, so it's okay.
So I look forward to having dinner with you in Bangkok.
Yes, yes. Okay. I'll put
Okay.
that in my notes. Okay, Stephen, nice to meet
Okay.
you. Thank you for your kind words, and thanks to everyone, and Liz and company, and Fiona and Jen for the invitation. Have a great conference.